I'll give it a sec and you
Yeah.
can start.
Okay, hi everyone. We're here today with Dr. Nicole Haydt. She is an orthodontic resident who will be speaking to us about her journey. So, if you have any questions throughout the presentation, please put them in the YouTube live chat and we'll go over them afterward. After the presentation is over, we will put up our quiz link. And now, Dr. Haydt, if you want, you can start.
Okay, thank you so much. Hi, everyone. Thank you for joining. So as Anita said, my name is Dr. Haydt, Nicole Haydt. I'm an ortho resident at CU Anschutz Medical Campus right now. So I'm in Colorado. And I'm in my second year of 3 years. So I'm just going to give you a little bit about my experience and hopefully give you some information about ortho that interests you. And if you have any questions, I'd love to answer them at the end. So I'll start off with just a little introduction about myself and then give you a little overview of ortho. I'm not sure, maybe some of you have family members that are dentists or have you shadowed before. So whether you know nothing about ortho or you know quite a bit, hopefully there's something in this presentation for everyone. And then I'll go over some case studies, some of my own patients and some of my co-residents' patients. I'll give you a little glimpse of what it's like to be a resident, and then we can go ahead and answer some questions. So a little bit about me. I was born in Sweden, but I moved to Southern California when I was really little. So I pretty much grew up in Southern California from Thousand Oaks. And I did my undergrad training in UC Irvine. So definitely a Southern California native. So yeah, I was in Irvine all the way till 2014, and I actually took a gap year. I took 1 year off between my undergrad experience and dental school. So if you guys are thinking about taking a year off, you can definitely ask me questions about that. What's good to do during your gap year? And I did my dental school training in New York City. I was at NYU, which I loved, and now I am at Colorado at the Anschutz Medical Center doing my last year here of ortho residency. This is a quick snapshot of what dental school was like. Everyone in dental school, probably the very first thing that you'll ever do once you get into the lab is you're going to get, you guys, you can see my pointer, right, Anita? If I circle things, yeah. So this is the very first thing you ever drill with your handpiece. You get this little block with pictures of teeth and this like plaster material, and you're just trying to drill into the shapes of the teeth. So I saved mine just as a souvenir, I guess. And this was my first cleaning I ever did. I did it on my mom, which was a cool experience. She came to visit me in New York City. So that was really fun. And here's some of my crown preps I was really proud of. I did 3 crown preps in one, so that was something I saved. It's a lot of hard work and you learn so much very quickly. But it can be a lot of fun and the challenges can be really fun too. These 2 pictures here, I actually got the opportunity to go on 2 global outreaches, which was one of my favorite parts about NYU is that they're really big on global outreach. This was the very first one. This was in Cambodia, and this was pediatrics only. So we were just working on children. And if you do go to a dental school that has global outreach, I highly encourage you go on one of these trips because you get to see a lot of patients and do a lot of treatment. And you're working very quickly, so you pick up your hand skills pretty quick. And this was my second global outreach. I was able to return as a leader on this trip, and I was in Nepal. So we had a really good experience on this trip as well. And if you have any questions, you're welcome to ask at the end. But dental school is also a lot of fun. I got my cat when I was in dental school. This is Oliver. If you're going to a dental school and you have an option of choosing, definitely consider your location. I loved my decision to go to NYU because I'm from a very suburban area in California, and I grew up in a very suburban area. I went to college in a suburban area. I wanted to try a city. So for me, New York City was a really big, cool experience, and I got to do a lot of fun things. They do a lot of boat rides in New York City. I met my boyfriend there, and this was obviously my graduation. So it was just a really fun 4 years. And dental school can be very competitive. Orthodontics specifically is a very challenging, competitive field. So once you finally kind of get into an ortho residency, you're just so relieved and you can finally enjoy. I'll go over in the presentation everything we're learning, but this is kind of all the fun memories of ortho residency, is just getting to be in your class. We have a class of 15 here at Colorado, so we're all very close. We do go on trips together. We did a Moab trip. We do some hiking together. We do ski trips. Just a really fun, it's been a really fun 2 years so far. So what does it take to be an orthodontist? Well, the path is long. It's traditionally 4 years of undergrad, followed by 4 years of dental school. And then ortho residency can be 2 or 3 years, depending on what residency program you get into. The one here at Colorado is actually 2.5 years. So it's right in the middle. But there's definitely, I don't know too much about the programs, but there's some programs where they combine like 3 years of undergrad with a guaranteed admission to dental school, and it'll be 3 years of dental school. I didn't go to one of those schools, so I can't speak too much on it, but there's definitely those options. So if you're in high school, you know for sure you want to do dentistry, those are good options to look into that I just didn't consider at that time. So what is orthodontics? Ortho, we're a specialty focusing on aligning teeth, and also we're also focused on the jaw growth as well. So traditionally what you'll see is braces. Some of you may be in braces or have had braces. You also have the option of clear aligners. And like I was saying, growth modification. When we see little kids, we have the opportunity to kind of aid how we would like them to develop and grow, which is a benefit in seeing children. So I'll give you the little quick, this is quick, I promise, of the history of ortho. They actually had evidence of some teeth being ligated together as early as 1000 BC, which I thought is interesting. That's way more, like way later than I imagined. But it wasn't until about 1723 with Pierre Fauchard that he created a first actual usable ortho appliance. And it wasn't very advanced. It's really just a base metal, and that they ligated the teeth to this metal base. And then getting into 1890, we have our father of modern orthodontics, who we look up to a lot still, Edward Angle. And he was the first to define what a normal occlusion or a normal bite is supposed to be. And we actually use his occlusion, his definitions of occlusion still to this day. So I'm actually going to lead into what that is. Some of this terminology might be new if I say buccal or distal, so ignore it if you're not sure what that means. But really your first, just focusing on the molars here at first. You see there's 3 molars, and there's 3 molars on the bottom. And your normal occlusion, ideal occlusion, is for your bottom first molar to be just a cusp in front of the top first molar. And that way all your teeth lock together really nicely. And all the teeth should be in a nice smooth curving line. So those are the 2 basic definitions that he came up with. And he also created these classifications further. This is a class 1 occlusion. You can see this first molar is just one cusp in front, and everything locks together pretty nice. We call this a class 1 occlusion. A class 1 malocclusion would be if that molar is locking in pretty nice, but there's some irregularity. There's still a little bit of crowding. Looks like there's some kind of overlap here. So it's not a great occlusion, but it's still class 1. So we say class 1 malocclusion. Malocclusion also meaning bad occlusion. And then this would be a class 2. So class 2, you see the molars are pretty much hitting end on. This bottom molar is supposed to be a little bit ahead, and it's actually just right on top of it. So this is probably the most common malocclusion, is having these teeth a little further back. So we call that class 2. Class 3 is the opposite. Class 3 means this molar is way ahead of where it should be. So far ahead that this person actually has a little bit of a crossbite. Their front teeth are behind their bottom teeth, which is not good. So that would be a class 3. And the only thing to make this a little bit more complicated for you is we divide class 2 malocclusions into 2 types. A class 2 div 1 is when your front teeth are kind of flared forward. And in a class 2 div 2 is, if you think of it kind of like a bowl, the front teeth are kind of pointing back, and then the laterals are pointing in front. It's kind of like a bull's horn. Or if you were to hold your fingers and put your like 2 center fingers back and your pinky and your pointer finger forward, that's kind of what it looks like. So that's the only other classification that makes this complicated. And other than that, it's pretty straightforward. Some basic definitions for you guys. This is a diastema. It's just any space between adjacent teeth. This is very common, maxillary midline diastema. It's like right between your 2 front teeth. Some people find this as an attractive trait, and some people prefer that diastema is closed. So that's a very good thing to ask your patients. Do you like the way this looks? Do you want this fixed? Because some people want to keep it. And usually when you have kids with diastemas, like 9-year-old, 10-year-old kids, those usually close on their own as they're getting all their permanent teeth coming in. But if it's continuing as an adult, that's not something that's going to close on its own. Crossbite, some of you might know what this is. So our top teeth should fit over our bottom teeth, kind of like a lid. And when our top teeth are fitting inside of our bottom teeth, we call this a crossbite. You could have a posterior crossbite, meaning that crossbite's happening in your back teeth, or you could have that crossbite with your front teeth, and we call that an anterior crossbite. So this is the anterior, that's posterior. This patient clearly has a posterior crossbite. And usually you'll see those crossbites if the top jaw is a little bit narrower than the bottom jaw. So it's why some of you may have had expanders or know someone who's had an expander in their life to kind of expand their upper jaw. This is what we refer to as an overjet. It's the distance between the front surface of your bottom tooth to the top teeth. So some people who have a really big overjet and their bottom teeth are really far behind their top jaw, we'll call that a severe overjet. A normal overjet, your teeth are pretty much touching, and it's about 2 to 3 millimeters of overjet is normal. An overbite is the vertical overlap of your teeth. So you want that to be about 1 to 2 millimeters of overlap. If it's more than that, like 4 millimeters, we call that an overbite, like a severe medium overbite. If your teeth are not overlapping at all, we call that an open bite. So open bite, and then these could be like a mild, moderate, severe overbite. So why do patients seek treatment? There's lots of reasons. Most common is psychosocial problems. People don't like to have crooked teeth. People, especially here in America, see straight teeth as a way for them to get a good job, to feel confident. It can have a big effect on the way you view yourself. And so that's probably the main reason that we see people come into the ortho office. Another reason could be function. Some people don't really care about the aesthetics as much. Their front teeth aren't touching and they're not able to bite carrots, and or basic function. They have cross bites that can hinder how they're eating. So oral function is a big reason. And also trauma prevention. Some people who have their top teeth that stick really far out are more prone to having teeth chipped or damaged when they fall. So that's another reason. As we advance, there's a lot of different braces options out there. we use all of these in my residency program. This is your standard traditional braces up here. On the right, these are self-ligating braces, so they don't need colors. It's just a door that closes and opens to let the wire out. Here you can see, I'm sure you're familiar with Invisalign. Clear aligners are very big now. We also do lingual braces in my residency program. Not a super popular option because they can be very irritating to the patient, but for patients who are looking for an aesthetic option and they don't want to do the clear aligners because they know they won't wear the clear aligners, lingual braces are a really good option for them. And also we have clear braces, which is very popular as well. We also have a whole other, this is not even all of the appliances that we use. We have endless amount of appliances and things that we can use to our advantage when moving teeth. These are kind of what we call space maintainers. So if like, let's say this person here, they lost a tooth early, we may use this kind of space maintenance. Even a general dentist would use this kind of Nance appliance to hold this space so that this molar tooth does not drift forward and then block out that permanent tooth from coming in. Same concept on the bottom. We call this a lower lingual holding arch. This here is a TPA. I actually had one of these when I had braces. We use these during ortho treatment as well. They're really good for de-rotating molars. You can use them to tie teeth to this appliance. These can be really good. And this one here, this torture device, as some of you may have experienced, as an expander. Here's a fancy expander. As some of you may know, as we age and we get older, the bones in our palate, they fuse. And so for adults that you need to expand, but their suture between their palate here is fused really tight. Sometimes we'll place screws directly into the bone. That sounds more painful than it really is. We numb the area and place these little screws. So that way the pressure is directly on the bone and it's more likely to open up this suture than if you were just to place it on the teeth like this. So we use TADS quite a bit in our residency program. Here's some more appliances. Carrier appliances, herps, forces. If you have questions about them, you're totally welcome to ask, but I won't go into the nitty gritty on them all. And these are the TADS, like those mini screws that I showed with that expander. We use them quite often. And they're becoming more popular as time goes on because anytime you're closing space, for instance, in this bottom left corner, if you were to just to put like a rubber band, like an elastic chain between these two teeth, you're going to have these teeth come back a little bit and you're going to have your back teeth come forward a little bit. But if you're looking at how pretty these teeth sit in with each other, you don't want these teeth to come forward at all. So having TADS is such a big advantage because you can put this screw directly into the bone and pull from the bone to the tooth. And now you're not touching these teeth at all. So you have a much better chance of closing the space all just from these front teeth moving back. So it really has become a big advantage and helps us do so much more. And that's the same thing going on here. This time up in the upper right, they have a coil spring. So it's kind of have a pulling vector on it here. And here they're probably trying to intrude these bottom teeth. I've never done this kind of mechanic, but there's so many different ways that people use TADS nowadays. So endless possibilities. And also, as I was saying, we have the ability to modify the way children grow. So for this girl here has what's called a reverse pull face mask. So she's most likely has a top jaw that is not as developed as her lower jaw. And so they're trying to pull her top jaw forward and try to stimulate some growth in that top jaw. So that's why she's probably having some rubber bands right up here that's attaching to her top jaw. Similar other ways of wearing headgear, depending on what your treatment goals are, you may want a cervical headgear, which is around your neck, a high pull headgear, which is around the top of your head. Here's a removable appliance that stimulates lower jaw growth. And here's another appliance, not removable, but a fixed appliance to stimulate lower jaw growth. So lots of options that we use. And that's what makes ortho so fun, is that it can be overwhelming that you have so many appliances and so many different ways of doing ortho. But that's really the fun puzzle of orthodontics in my mind, is because there's really no one right way of doing something. It's a puzzle. You can do it the way that works for you, that works in your hands. We have some faculty at our school who will use an appliance that another faculty swears never works for them. So it's really just what works for you, and you can kind of brainstorm and puzzle things together. So what do you need for a good diagnosis of a patient and a good treatment plan? It all starts with a patient interview. And you're asking open-ended questions when that patient comes into your chair. I'm asking them, what brings you in today? And what bothers you about your teeth, your smile? What goals do you have from getting ortho treatment? And really open-ended questions to see where they're at and what they're looking for. And as soon as you ask that question, that open-ended question to that patient, the best thing any doctor can do is just be absolutely silent and let that patient talk until they're done talking. Even if there's a little awkward silence, wait for them just to make sure they're finished, because usually they'll tell you everything you want to know in that first visit about what they're really there for and what they want fixed. And that's going to dictate a lot of what you do. And to help out with your exam, you not only do a clinical exam where you examine the teeth, but you're also going to be taking photos. We take, I'll show you a usual what we gather from a patient. We take extraoral photos, which means we're taking pictures of their face. Intraoral photos, meaning inside the mouth. So we take pictures of their teeth. We take x-rays. We take two different kinds of x-rays in the ortho office. We call them a pano and a ceph. I'll show you what they look like. And diagnostic casts. So we take impressions. Either we take a digital scan or those fun alginate impressions that everyone hates. And those diagnostic casts are really important because it helps you really see those teeth outside of the patient's mouth. And you might be able to see things on those casts that you didn't pick up on in the patient's mouth. So that can be really helpful. This here is, I guess we do take occasionally a third type of x-ray, but this is our basic ceph x-ray, and we get a lot of measurements from this. On these ceph x-rays, you're looking at how the teeth relate to each other, how the teeth relate to the skull, what the face proportions look like. And we take a lot of points on these x-rays and make a lot of measurements that help us diagnose this patient and see if they're having a skeletal problem or a dental problem. Here, it might look a little complicated, but this is a diagram of the vertebrae. So it's taking the vertebrae and putting them in a little cartoon form here, and how we stage a patient to evaluate where they are in their growth. That's one of the cool things that we can do in ortho. We can figure out like, are they at their peak growth yet, or they still have some more time? And we can take advantage of their growth to adjust how their jaws are growing. So we kind of base how much they're growing based on how curvy you can see these vertebrae get. When you're young, they're really flat. And when you're an adult, they're really nice and square and curvy. So we use that a lot to stage these patients. And these are rare that we take a hand wrist film, but these can be really helpful if, let's say, the patient is going to be going into surgery, and knowing if the patient is done growing is very important if you're going to be doing surgery for them. So we might take a hand wrist film just to see where they are in their growth, because you can tell a lot by the bones in the hand. This is a bone, it's called a sesamoid bone. If you see this, they're pretty much at their peak growth when you see that. I don't know if you can see it, it's very little. There's a tiny little bone there. So a lot of information we get from these x-rays. And why is it so important? Like I was saying, with expansion is one of the big things that we look at. You can see, am I going to have an easy time expanding this patient? Is there suture fused? If it's not, then I can just put in a regular expander and I should be able to open up that suture. If you're kind of unsure, if they're like 15, 16 years old, it's kind of hard to tell if they have more growth left. So you might take some x-rays and see like, oh, they're actually like way ahead in their growth, or they're like, oh, behind kind of in their growth based on their age. Because age does not determine where a patient is in their growth. It's way more accurate to be testing based on their skeletal pattern. Is their lower jaw too small? Is there any chance of encouraging some more minty growth on the lower jaw? Lots of things that we can use to our advantage. Types of orthodontic treatment. So space maintenance, we kind of touched on. This is something that general dentists do all the time. They'll place a Nance, or they'll place a lower lingual holding arch, or they'll place like a band and loop on a tooth just to save space if a patient lost a baby tooth early. And we do that as well, waiting for permanent teeth to come in. Phase 1 treatment and phase 2 treatment. There used to be a lot more controversy on this than I think there is now, as we understand the value of phase 1 treatment. We don't do phase 1 treatment on every patient just because they're 7, 8 years old and we could do something to help them. Phase 1 treatment should only be something you do for a patient if it's going to make their total treatment more effective or more efficient. And there's only a few case scenarios where we really do phase 1 treatment. A lot of patients can wait until they're older for a comprehensive treatment, but there definitely is a value for treating some kids early. And that's why we separate their treatment into phase 1 and to utilize some of the growth that they have and into a phase 2. We do splint therapy. We're lucky enough to have some really good faculty who are experienced with TMJ, the joint that you have up here. And so we make splints often for patients if they're having any TMJ disorders, they're having any pain in their joint, clicking, popping, that's painful, or if they have any jaw asymmetries, we use splints to kind of help us figure out where their jaw is most comfortable. Clear aligner therapy, aka Invisalign, is the big shot for clear aligners. And we also combine ortho and orthognathic surgery quite often. Well, not quite often, but we definitely have cases in our residency where we do surgery for patients. Sometimes orthodontics is not enough. Sometimes you do have to combine surgery if you have a patient with more of a skeletal problem versus just a dental problem. So you can combine and work with oral surgeons. For our clinical examination, we look at so much for every patient. First thing that's most important anytime you're dealing with patients is figure out their health, make sure they don't have any medical problems, that their teeth are, medical problems that would conflict with the treatment. Dental caries and periodontal disease, you want to make sure that's managed before you do any orthodontic care. You don't want to put a bunch of braces on teeth that have a bunch of cavities on them, and then the dentist is trying to work around your braces and wires to fix cavities. So make sure all that stuff is taken care of first. Oral function. So not just with chewing and eating, but the way our teeth our position can really affect our speech as well. So that's one thing we assess, and the way they're chewing, eating. Sleep problems, there's some connection to sleep apnea and to malocclusions and TMJ function. And then I'm going to dive in a little bit deeper into our full clinical exam that we do about the facial and dental appearance. Here on the right, you can kind of see a little bit macro aesthetics, mini aesthetics, and micro aesthetics. So I'll go into each of those and give you the brief snapshot of what we're looking at. For macro aesthetics, that's looking at the face as a whole. You're not really looking at the teeth yet. You're just looking at the face. And our face is a ideal, what's considered an aesthetic face is when you divide the face in 5, like this, in fifths. The pupils should be at a certain area in these fifths. The nose should be within a certain area. The eyes should be in a certain area. We also divide the face in thirds vertically. So usually you want your nose in the middle third, and for the lower half of the face, which is the one we're most able to affect, we want the distance between your lip here and your nose to be 1/3 of the distance, and the space between your lips here and your chin should be 2/3 of the distance. So some people have a very short lower facial height, or some people have a very long lower facial height. And those are things we can affect with and change with when we're dealing with teeth and braces. And another way, we look at the profile as well. So this would be a person with a convex profile. Their chin is a little bit further back. This would be someone with a straight profile, and this would be someone with a concave profile. Probably reminds you of Jay Leno, that strong, prominent chin, kind of a concave face. So these are definitely things we look at, and we can change to some degree. Mini aesthetics would be how your teeth and smile relate to your face. When you look at your teeth in the mirror, they should follow your lower lip kind of in the same curve as your lower lip. This is what we consider aesthetic and ideal. Here in the middle, you can see someone who has a very flat smile arc. So their teeth, they're pretty much straight across. They don't follow this lower lip quite as well as that first picture. And then in this last picture, this is someone that we would say has a reverse smile arc. So instead of being a nice curve following the lower lip, it kind of has the opposite effect here. So the teeth kind of go up higher. And obviously that's not quite as an aesthetic look as you have in this first picture. And microaesthetics are how the teeth relate to each other. And this here is based off of, we use a golden proportion. You'll learn about it in dental school, and we use it a lot in ortho. And it's a proportion that's based on the Fibonacci sequence. And it's based off what's beautiful in nature. So naturally, our eye is drawn towards this kind of sequence, and we see it in our teeth as well, where your front tooth is considered one. Your lateral incisor should be 62% of the width of your central incisor, and so your canine should be 62% of your lateral incisor, and so on, so on, so on. So it kind of follows that same sequence that we see in art and in nature, and we try to replicate that with our teeth as well. Okay, I'm going to go into a couple case studies for you guys. This is an example of a phase 1 where we would want to treat this patient early. So you can see she has an anterior crossbite. Her top teeth are behind her bottom teeth. And some problems that you might be able to foresee with this patient is trauma. She might be biting her front teeth on her bottom teeth, so they are more likely to chip. Also, when you have cross bites like this girl has, she is probably shifting her jaw to accommodate where her teeth are. And anytime that you're shifting your jaw while you're growing, she is changing the way that her jaw is growing because of her shift. So there's actually research. If let's say this girl is constantly shifting her jaw over to the right to have a good bite, her left jaw could end up growing longer than her right jaw because of the way she's biting. And once this is established and she grows up to be an adult, that's fixed. Her left side of her face will always be a little bit longer than her right side of her face. So this would be a reason you would be like, yes, let's treat this girl early. It would be efficient. It would be effective for her to get her started early. So she got an expander to expand her upper jaw. And she also had braces put on with little push coils here to help move her top teeth forward. This was a progress for her. And this is her when she was all done. Obviously, she still has baby teeth. This is a baby tooth. That's a baby tooth. As soon as those permanent teeth come in, she's probably looking to get a phase 2, most likely, so that she can have all her teeth nice, straight, and pretty. Second case, Invisalign. A lot of adults, teens don't want to go back into braces, so Invisalign is a really good option. This patient specifically was not happy with all the crowding that she had. So she did Invisalign treatment, and this is her progress. And you can see she's pretty edge to edge with how she's biting here. She has what we do a lot and often in Invisalign is we do something called IPR. It's where we shave off a little bit of enamel, that outer protective surface of the teeth, just a little bit between the teeth, just to create some space. So once you have that space, you're able to gather these teeth back a little bit, and she's able to get a nice bite. And we do IPR with braces as well, but it's very minimal shaving of teeth that you're doing. This is a patient who had extractions done. This is her initial pictures, and her chief concern was that she did not like her open bite. You can see her tongue sticking out here. She might have a little bit of a tongue thrust that's keeping the space open. But our biggest concern for her was that her front teeth are very proclined, meaning that they're sticking out pretty far. And this puts them at risk for trauma, and it's also not a stable, healthy position for teeth. So the best option for her was to take out 4 teeth. They took out 4 premolars, created some space in order to move those teeth back. And you can see it didn't damage her profile. She already has kind of, if I'm going back to the initial now, it's hard to tell because I chopped off some of the profile here, but her lips were sticking pretty far out. You can still see here they're a little bit full, but for some patients, they're able to, with good lip support to start, they're able to handle extractions because you're moving the teeth back and the lips follow, but they don't follow as so much to make her look like a little old lady. She looks pretty good here, I would say. And she has a really nice result after those extractions. You can see the difference on this x-ray, how much her teeth stuck out in the beginning and how they look really nice right now in that last picture. Here's another patient with an open bite, but this one was a little bit more severe. And one of the biggest challenges with patients with these open bites is the long-term stability. You might see videos of cases on Instagram, or you've seen where people are able to just put braces on these cases and have the patient wear rubber bands and close this bite, and now their front teeth are have a good overbite and they're touching. And then you look at them 6 months later and they're back to an open bite. And that's because the diagnosis wasn't done well. You have to really look at these x-rays. And in this case, this man has really strong lower jaw and kind of a setback upper jaw. So for him, the best treatment option for him was a double jaw surgery, meaning they did surgery on both jaws. And you can see here in their final x-ray, they moved his top jaw forward a little bit and his bottom jaw back. And they also did a little bit of rotation in those jaws to help close this bite. Closing an open bite with surgery is a lot more stable than if you were just to do orthodontics alone. So for him, he's going to have a much more stable outcome in years to come, not just in the next 6 months. So he's going to have a really good result. And this is him currently. This is one of my patients. This is a patient who has Cruz-on syndrome. And if you don't know what Cruz-on syndrome is, which I don't doubt, I've never heard of it till ortho, so I wouldn't blame you if you hadn't heard of it. This is a syndrome where the sutures in the skull and the face, they fuse early. So like we were talking about before, you have a suture right here in the middle on your palate where these bones fuse as you get older. For this young boy, this suture fused Probably it already fused already at this point because we tried to expand and we couldn't for him. It was pretty fused together. So you can see that's also why he has a very vertical growth pattern to his face. They did do a surgery to kind of open up one of the sutures, but his overall growth pattern is very vertical because of the way his skull is developing. And these patients can be a little bit challenging in the sense that you don't always know what all the teeth that you're working with. So this was his pano x-ray, his Panorex. And when I took this Panorex, I was like, oh, what's this going on up here? And this is his canine that's going up towards his nose. So that's kind of a goner for us. At this point, there's no hero move to turn this 180 degrees and bring this into his mouth. So you really have to be a problem solver, and you have to be good at puzzling to figure out what you're going to do for this boy to give him a symmetrical smile, and what you're going to do about kind of these anomalies that he most likely has. So for him, we did expansion, and after that expansion, we found another tooth that we did not see in his initial x-ray. I'll go back to that x-ray. That was on his left side, and this is his left side. That tooth is hidden somewhere around here, which is kind of where my pointer is. That's where his tooth had to have been, and it just didn't show up on his x-ray until it came into the mouth. So for any patient with craniofacial anomalies, you have to be flexible. You don't know what teeth are going to be there. You don't know what teeth are going to come in, which teeth are going to be useful. This tooth is so far out of the arch that we took this tooth out. And you can see that he was missing that canine on that right side because that canine was going up towards his nose. So we're deciding just to leave that tooth. It's not going to do any harm for him. If anything, if it starts coming up out of his nose, then we'll send him to surgery, but it's not doing any harm for him. It might just stay exactly where it is and never bother him. So we're just not touching it. So he actually ended up being pretty symmetrical because we don't have a tooth, that canine on the right side, and on his left side, we're taking this premolar out, and he will have a canine coming in. So he does have the same number of teeth on both sides, and that's kind of the best outcome you can give for him. And we're just waiting on permanent teeth to come in. Let's see. No, that was not it. So another thing with patients with, let's say, cleft lip and palate or Crouzon syndrome, you usually work these patients not into 3 phases rather than just phase 1 and phase 2. His phase 1 is just to get all the teeth that we can salvage into his mouth. His phase 2 is to get his teeth nice and straight as possible. His phase 3 down the line is looking like surgery. He'll probably be a surgery case, but he's only 9 years old right now. So that'll be far in the future that we would do a 3rd phase for him. This is another a patient who had, if you can zero in your focus right here onto his palate, you can see he has a tooth. This is his canine, his right canine. And I had an impacted canine. Some of you might have impacted canines. They can be pretty tricky to get in, especially for him, because he was very crowded. If I were to look back at this case and do it over, I might have taken teeth out to make it easier, but they opted to make space for that tooth, and they brought this tooth in with what's called a Kilroy spring. And this Kilroy spring is pushed down towards the tooth and tied to the tooth. And then this spring wants to pull the tooth. So it's constantly pulling the tooth back towards the arch. So this was a cool case to get his canine into the arch. And I thought I had a picture afterwards, but I guess not. So those are a bunch of the cases. You're totally welcome to ask me more questions. I kind of rushed through them all. So I hope I didn't go too fast and lose you. To give you a basic rundown of what ortho residency is like, for Colorado at least, we take 15 residents per year. A lot of schools will take somewhere around 4-6 residents per year, just depends on where you're applying. I like having a big group. I was used to a big class size at NYU, and so I kind of wanted to stay in a large class size. So I'm having a lot of fun with all my residents. Your first year, no matter where you go, you're probably looking at like 80% book work and just studying and learning about biomechanics and the history of orthodontics and basic occlusion, growth and development as a big class. And then you're just starting to get your feet wet with clinical, and you're starting your patients and you're taking records and doing x-rays and photos on your patients. In your second year, you're probably 50% book work, 50% clinical. So now you're starting more patients, you have more patients in active treatment. And by your last year, you're doing very little book work and you're mostly just focused on your patients. You have a big roster at that point of patients, and you're just trying to focus on finishing their cases and taking braces off, which is always fun. Enjoying all the fruits of your labor in your last year. And I think that's about all I have for you guys, because I want to give some time for some questions. So thank you so much for listening. Are there any questions out there?
First of all, thank you so much for your amazing presentation. We do have some questions. So our
Cool.
first question is, how many patients do you get to see in residency per day or per week?
That's a good question. Let's see. I see about 8 patients a day. Um, and I'm a second year. When I was a first year, I probably saw 4 patients a day. Um, 4 patients a day, but only 3 days of the week. So maybe 12 patients a week. And now I see, let's see, 8 patients a day for 5 days. So about 40 patients in a week. So more or less. So now with COVID, it's taken a big toll on how many patients we can really see, because we have to have our chairs 6 feet apart. So we're sharing our chairs. So honestly, it's a lot less now with COVID, unfortunately, but usually you can see 8 patients in a day.
Another question is, what made your experience at NYU different from any other school?
Well, I only went to NYU for my dental school, so I can't speak for other schools. But what I did love about NYU was I did like the large class size. I feel like that's where I thrive, is if there's clubs or other things going on in the school, that interests me, and then I have a good time. I loved the global outreach aspect of NYU because that's one of their strong suits, because of where NYU is located. And because they're such a large school, they do have the opportunity of putting together amazing outreaches. And they do about 4 outreaches a semester, I want to say. So that's why I was able to go on 2, even though we were such a large class size. And also, it's just a really, really fun city to be in. If you haven't lived in a city before, just a city environment, you have birthdays of your classmates. And so you can go somewhere new every weekend. There's so much to explore in a city, so much to do, so much good food. And you're putting so much money into school already. It's like worth it to just put in a little bit more to actually really enjoy your 4 years and your experience.
Another question is, what made you want to get into orthodontics?
Okay, that's a good question. I started my braces when I was in high school, and I had an impacted canine. And my orthodontist, he had his 2 assistants leave in the same week. And so he was struggling to find an assistant. So he just called me and asked if I wanted to assist him. And I was looking for a summer job to scoop ice cream. So I was really excited to have a summer job doing something like really cool, like being in ortho office. And that's what made me fall in love with it. He was a really good teacher to me, and he did more than just employ me. He would sit down and he would teach me about the teeth when we had time, and he would teach me what he was doing and teach me about the wires. And I was just really fascinated with how you can change someone's confidence just by changing, aligning their teeth. My confidence totally changed when I was in high school. I hated when I had braces. I never smiled when I had braces, but as soon as I had them off, it's such a big, powerful moment for a lot of people. And that carried with me enough that I wanted to do that.
What do you think is the most fun part about orthodontics?
Oh, that's such a good question. It's so hard. There's so much fun. I think the biggest part is the puzzle aspect. I just love every case is going to be so unique, so different, and you could do something totally different to that patient than someone else would choose to do, and you're still both going to get a really good result for that patient. So you can't really you're working with the best population too. You're working with mostly people who want to come and see you. My experience working in general dentistry, you're working with a lot of people who are in pain or uncomfortable, and they don't want to see you. They're scared to see you, but people are usually generally pretty happy to come see the orthodontist. So that's a really fun part. You just get a lot of good patients. And even today, I took braces off a patient today, and he was so happy. He gave me a gift card this morning because he was just so happy, which he obviously didn't have to do, but it was just like they are just like really happy to come see you, and it's a fun environment when you're appreciated and you're doing good for others. It's nice.
What kind of cases do you enjoy working with?
um wow, all of them really. I love my phase one patients. I love my little kids, because they kind of break up the day. Usually they have, just funny questions to ask you. There's always something new with 8-year-olds. I don't know what it is, but what they're learning in school, they want to tell you all about it, and they have like fun, super random fun facts. I just love like that patient population, but it's I mean the enjoyment I get from all the cases, but I do love my little kids who just have like fun new facts to share with me. It's always exciting.
What kind of cases do you typically deal with?
Okay. Typically, I mean, we do everything. We do really do everything. The patient that I took braces off this morning, he was an adult. He was a limited case. He just really didn't like his front tooth. So we only put on brackets on 8 teeth in the front just to fix that one tooth that he didn't like. And that was all we did for him. But I have a lot more complex patients as well. I have a patient who she is an adult now, but when she was in high school, she was kicked in the face playing soccer. So her whole jaw has grown asymmetrically, and her chin is all the way to the left. And she has pain and damage to her joint. So she's a very complex case. She is splint therapy, she's ortho, she's surgery, she's all of it. And you're talking to the oral surgeon, you're talking to your TMJ specialist to really make sure you're giving this patient the best treatment. So it really is everything.
If you were to give your younger self advice, what would you tell yourself?
Oh gosh, that's a tough one. Take care of yourself. I feel like go if you're choosing dentistry, it's a long road ahead, and it's so important to take care of yourself amidst all the stress. I remember in undergrad being very stressed because I felt like I needed to get a certain GPA, I needed to get certain grades, and you're constantly thinking about it. And every test you take, it's determining your life, you feel like. And so I didn't sleep very well when I was an undergrad because I was stressed a lot. I didn't really eat very well either. And if I could go back, I would have taken care of myself a little bit better because it's a long road ahead. It's a lot of years, and you want to make sure that you're not hurting yourself in the process.
What kind of study tips and techniques are you going to give pre-dental students who are going to take the DAT?
Oh, wow. It's been a while since I've taken the DAT. So the advice, like I'll give you some advice, but the advice I give you might be outdated. Um, but I really liked there's certain resources I'll give you that I use, and I hope they're still helpful. I used let's see, Crack That PAT. It's an online program for the PAT section, and PAT section is really looked at by dental schools, and that was one of my strongest sections, which I think is what helped me. And I only use that online software, Crack That PAT, and it's very very similar to what you'll actually experience on the exam. So I really like that one. Um, let's see. I did a Kaplan Blue book, DAT book, which I really liked. I love the Kaplan books. I feel like they've helped me in a lot of my standardized testings, but I did a Kaplan Blue book. Give yourself some time when you study for a DAT. Don't I like okay, I guess my one big advice that I can give you is don't spend as much time reading as you do doing practice questions, because you've studied the material through your undergrad courses. You've done OChem, you've done bio. There's no time for you to reread everything that you've learned. The best thing you can do is get a hold of practice questions out there, practice questions from books, practice questions from online. I know there's like one free DAT practice exam. Take that to see what the exam questions are going to be like. And then if you have a weakness in those practice questions, then read and study that material. Excuse me, and get comfortable with that material rather than I would spend so much time reading textbooks that I don't know how much of that I retained. I think I was just wasting my time just reading. Practice questions are the best way to go.
I think this might be our last question. Did you do any research as an undergrad?
I did not in undergrad, and I think it would have helped me if I did. So if you do get into a research position undergrad, totally recommend it if you have the time. Don't kill yourself about it. If you don't have the time, you don't want to overload your plate if your grades are going to be slipping. But I did not do research in undergrad. I did do research while I was in dental school, so I did several research projects then, and that's definitely a must. If you want to specialize in ortho, they're definitely looking for research in dental school. It can be anything you're interested in as long as it's something.
What kind of clubs and activities did you take part in undergrad and dental school?
Do whatever you think is fun. I was in a sorority when I was an undergrad. I played on ultimate frisbee traveling team, so we spent so many weekends going up and down the coast of California. We'd go to other schools and play ultimate frisbee. I couldn't do pre-dental club at my school because it was always on a Tuesday, which is always when I had practice, and I just do what you have fun with. Dental schools aren't going to be looking that you did X, Y, and Z extracurriculars. They just want to see that you did something and stuck with it. You took some leadership opportunities in it. With whatever you're doing, it has to be something you're passionate about. So I wouldn't worry too much about specifically what you do as long as it's something you enjoy.
Okay, I think that's the last of our questions. Thank you so much for presenting with us today.
Oh, you're so welcome. Thank you so much, guys. It was fun being here. Thank you.